Welcome to The Explainer. Today, we're unpacking a super high-stakes, real-world clinical scenario that perfectly captures the incredible tightrope walk of occupational therapy. We're diving into ACOTRO Case 7, focusing on Miss Jessica Patel. She is a 42-year-old professional chef who is literally fighting to save her entire career, and frankly, her core identity, after a severe hand injury. This case is an absolute masterclass in clinical reasoning, and I am so excited to guide you through it.
Okay, let's dive right into this. Here is our roadmap for Ms. Patel's rehabilitation journey. We'll be covering 1. The chef's post-op referral, 2. Safe assessment protocols, 3. Mapping the rehab journey, 4. The vocational ultimatum, and finally, 5. The gold standard resolution.
Section 1. The chef's post-op referral. So let's set the stage. The referral hits our desk right as Ms. Patel is exactly 10 days post-operation. The injury? A surgically repaired flexor tendon laceration to her right dominant hand. For a professional chef, someone whose entire livelihood depends on heavy pan lifting and lightning-fast fine motor precision, this isn't just a medical issue, right? This is an absolute vocational crisis. To really grasp the severity here, we need to look at the anatomy. Ms. Patel suffered a Zone 2 flexor tendon repair. In the medical world, this specific anatomical region is notoriously dubbed no man's land. And why is that? Well, it's a tight, crowded sheath where the superficial and deep flexor tendons intertwine. At just 10 days out from surgery, her repaired tendon is in the early fibroblastic phase of healing. That means it has almost zero tensile strength. It is incredibly fragile, highly vulnerable to getting stuck in dense scar tissue, and at a massive risk of a complete catastrophic rupture if it's loaded prematurely.
But hey, we have to remember the human being behind all this biomechanics. When Ms. Patel first comes in, she is absolutely terrified. She tells us, "I'm worried I'll never be able to cook professionally again." This single quote humanizes all the intense clinical data we just looked at. Her injury immediately and profoundly threatens her livelihood, her family's financial stability, and honestly, her core identity as a chef. The emotional stakes here are just sky high, and as therapists, we've got to treat that anxiety just as seriously as we treat the physical tendon.
Now, before we even bring Ms. Patel into the assessment room, we have to do our homework. Following the Canadian Practice Process Framework, or CPPF, this is our enter and initiate stage. A gold standard therapist absolutely must perform an essential pre-clinical review. We need to audit the surgical report. Was this a robust 4 to 6 strand core suture, or was it a weaker 2-strand repair? We're checking for nerve lacerations, identifying the surgeon's exact protocol, like a modified Duran, and screening for any systemic factors like diabetes or smoking that might slow down her healing. And we can't forget institutional factors like workers' comp and workplace policies, because we already know getting her back to that kitchen is the ultimate goal here.
Section 2. Safe assessment protocols. Now, what's really interesting about this next part is what happens when she actually arrives in our clinic. She drops a total bombshell. Driven by this immense guilt over not being able to help her family, she admits she actually took her splints off the day before just to try and chop some vegetables. She is in pain, physically and emotionally. Because of this scary admission, our assessment toolkit has to gather vital data without placing an ounce of mechanical stress on that delicate Zone 2 repair. We use the Canadian Occupational Performance Measure, or COPM, to identify her priorities and shift her focus from pure fear to productive goal setting. We use functional observation to see exactly how she's compensating during daily tasks. We objectively measure her edema with millimeter rings. We track scar maturity with the modified Vancouver Scar Scale once those sutures are out. And we measure range of motion, but strictly within the surgeon's permitted limits to ensure that tendon is gliding safely. But listen, here is the absolutely crucial takeaway from this whole assessment phase. This is an absolute non-negotiable contraindication. Do not, under any circumstances, perform grip or pinch strength testing at 10 days post-op. Remember the biological reality we talked about? The tendon is still in that fragile fibroblastic phase. The forceful isometric muscle contraction required to actually test her strength would place a massive load on the suture line and practically guarantee a catastrophic tendon rupture. Our primary directive here is simply to do no harm.
Section 3, mapping the rehab journey. So, now that we have our safe assessment data, we translate all those clinical findings into a concrete, holistic occupational formulation, Basically, we need to map out exactly how we're going to get her from this fragile, anxious state safely back into a bustling commercial kitchen. We organize this using a CMOP-E analysis. Looking at the person domain, we clearly see the vulnerable tendon repair, the edema, and the acute anxiety that's driving her splint non-adherence. Under the occupation domain, there is a complete inability to perform her professional duties or honestly even basic independent self-care. And then there's the environment domain. This is where the true friction lies. We have an undeniable vocational collision happening right here between her strict restrictive surgical protocols and the heavy load, rapid pace demands of her commercial kitchen. To actually navigate this collision, we have to pace her recovery with a very clear timeline of SMART goals. By week 2, we need 100% accuracy in her precautions, so absolutely no more rogue vegetable chopping. By week 4, we're aiming for independent dressing and meal prep, but using adaptive one-handed techniques. Fast forward to week 6, she should achieve active range of motion targets to safely grasp light objects. By week 12, we want her simulating kitchen tasks for 30 minutes without pain. And finally, by week 16, the ultimate goal, safely returning to modified professional duties with full medical clearance. So how do we hit those milestones? By deploying our CMCE enablement skills. We're educating, we're coaching, and we're adapting. Our comprehensive intervention strategy involves keeping her in a custom dorsal blocking orthosis, which is specifically set at 20 to 30 degrees of wrist flexion and 50 to 60 degrees of MCP flexion. This eliminates tension on the repair. We use the modified Duran protocol, focusing on controlled passive flexion and active extension to safely promote that tendon gliding. We're actively managing edema and scars with retrograde massage and silicone gel. And, crucially, we introduce one-handed adaptations. Think non-slip matting and adaptive cutting boards so she can actually participate in her daily life while her tissue heals. We are constantly balancing tissue protection with practical functional training. Section 4, the vocational ultimatum. But, rehab is rarely a straight line. Just as we hit week 4, Ms. Patel comes into the clinic in absolute distress. That carefully mapped journey we just looked at, it's about to be completely derailed by outside forces. She sits down and tells us, "My employer told me that if I don't return to work next week, they may replace me." This is a massive clinical twist. Under this intense financial and emotional pressure, she admits that she's been taking her splint off at home, again, to practice cutting and chopping. She is desperately trying to regain her skills before she loses her livelihood. So, I want you to pause for a second. Put yourself in the gold standard occupational therapist's shoes. You are facing a potential therapeutic and medical disaster right now. Your patient is actively defying strict post-op protocols because she is terrified of losing her job. What are your immediate clinical priorities in response to this safety breach and this intense employer ultimatum? Well, first things first, you've got to assess the structural integrity of that repair. We need to rule out an occult tendon rupture right then and there. Second, you have to de-escalate her panic. You absolutely cannot scold her here. You must use deep empathy to validate her very real financial fears. But medically, you must firmly advise against returning to full duties next week. At 4 weeks post-op, returning to active chopping and heavy lifting carries a near certain risk of complete tendon rupture. You have to patiently re-educate her on the biological reality of her healing tissue. Section 5, the gold standard resolution. So we're at a total impasse. We have the biological limits of a healing tendon colliding directly with the economic reality of a demanding employer. It's our job to mediate this conflict and find a pathway forward that protects both the patient's hand and her career. And honestly, this brilliantly illustrates exactly what makes occupational therapy so powerful. We don't just treat the hand, we treat the entire occupational context. We start by validating her emotions and exploring exactly why she was non-adherent. We then provide clear visual education, literally showing her how the tendon glides and exactly why early loading causes it to snap. Then we take systemic action. We get her written consent to directly mediate with her surgeon and her employer, proposing a highly structured, win-win graduated work entry plan. And here's what that protocol actually looks like in action. To keep Ms. Patel employed and on the payroll without risking her surgery, we advocate for strict workplace accommodations. For weeks 5 through 8, she performs only sedentary, administrative, 100% non-prehensile duties, stuff like menu design and ordering ingredients. Zero heavy lifting, and she wears her splint 24/7. From weeks 9 to 12, we introduce light, non-forceful bilateral tasks, like monitoring sauces and plating, but absolutely no heavy knife work. It's only at week 13 and beyond that we gradually progress her back to standard tasks, and even then, only after she passes formal grip strength clearance.
Now, to lock all of this in, our professional documentation has to be flawless. Following the SOAP format, our subjective notes capture her severe vocational stress and her admission of removing the splint. Objectively, we clearly document that at 4 weeks, the incision is intact with no sign of a full rupture. Our assessment highlights the critical risk of surgical failure due to that employer pressure, and our plan details our exact systemic interventions, re-educating the client, directly contacting the employer for modified duties, and providing safe, adaptive tools for her home. This level of documentation proves advanced clinical reasoning and fierce client advocacy.
Ultimately, Ms. Patel's case is a profound reminder of the intense complexities of rehabilitation. It leaves us with a really critical question to consider. When a patient's livelihood physically threatens their biological healing, exactly how far should a therapist go to intervene in their outside world? As we've seen today, sometimes protecting the tendon means stepping right out of the clinic and directly into the workplace. Thank you so much for joining me for this explainer, and keep exploring that incredible balance between medical science and human reality.